Good morning, everyone, and welcome to the Future of Telehealth in Latin America webinar. We're hosting this event by FrontierView in collaboration with our global partners at Global Health Intelligence. My name is Brenda Lora, and I'm a Managing Director at FrontierView. Thank you for joining us this morning. To start, I would like to provide you a brief background on our firms and how we work with executives at major multinationals. FrontierView provides the world's best market intelligence and advisory services to global business leaders. We help our clients grow and win in their most important markets by providing support to inform their decisions and workflows, particularly around market monitoring, strategic planning, and international growth. Our dedicated teams around the world serve as advisors and trusted partners to more than 4,000 leaders. And we work with the world's top Fortune 500 companies around the world. Within them, we're supporting the regional team, especially in Latin America, across 60 healthcare companies. We're delivering decision support and forward-looking insights to key private and public markets. And our objective is to help you, our clients, to succeed at all points of your business cycle. Through our unique strategic intelligence and service model today, we're helping many business leaders to make better decisions. You can follow us today and download our FrontierView mobile app at iOS and for iOS and Android devices. Today, we're also delighted to introduce you to our partners at GHI. The firm was founded in 2014 and it's pioneered the development of the largest hospital database focused in Latin America. Today, Hospice provides the most reliable source of demographic data on hospitals across the region, including the installed base capacity among other key data points. Through a combination of primary and secondary sources, Hospice maintains the insights much needed today, especially as we have seen the pandemic reshape the hospital infrastructure across the region. If you're interested in upgrading your partnership with FrontierView to receive access to this invaluable resource, please contact us to learn more. So with that brief overview, I'd like to introduce you to our presenters. First, Mr. Guillaume Corpar. He's the founder and CEO of Global Health Intelligence. With over 20 years of business consulting experience, Mr. Corpar supports life sciences and medical device companies in their growth plans. Mr. Corpar has a BA in Marketing and Entrepreneurship from HEC Montreal, where he received a Record of Excellence Award. He also holds a degree in Scaling Businesses from the Stanford School of Business in California. Guillaume, welcome. Next, I'd like to introduce you to Alec Lee. Alec leads our healthcare practice for Latin America at FrontierView. His work focuses on the development of management best practices in digital health, and he contributes extensively to our analysis on policy developments impacting market access and reimbursement conditions in our region. Alec previously worked in the economic and political section of the U.S. Department of State in Rio de Janeiro, and he holds a bachelor's degree in political science from Oklahoma State University. He also holds a master's degree in international relations with a concentration in international political economy from the University of Sao Paulo. Alec, welcome. Finally, and last but not least, I'd like to introduce you to Dr. Enrique Ruelas. He's a physician graduated from the School of Medicine of the University of La Salle in Mexico City. He holds a Master's of Public Administration from Centro de Investigación y Docencias Económicas and a Master's of Health Sciences and Administration from the University of Toronto. Dr. Ruelas is currently the President of International Institute for Health Futures and the Professor of Health Systems Management at the School of Medicine of Universidad Panamericana in Mexico City. In addition, Dr. Ruelas has served as Secretary of General Health Council of Mexico, a position similar to Surgeon General, where he was responsible for leading the effort to cope with the influenza pandemic in 2009. Dr. Ruelas is also the author of more than 15 books and 60 articles published on the future of health. Dr. Ruelas, it's a pleasure to have you here. Welcome. Now let's get started to talk a little bit more about the agenda. The structure of our webinar today will consist of a 45-minute moderated discussion followed by Q&A. You can submit your questions to FrontierView webinars through the Q&A box on the right-hand side of your screen. We will first explore the current state of telehealth and electronic record penetration across the hospital's infrastructure in the region. We will then dive deeper into key trends behind the adoption of telehealth across the region, and we will provide you a forward-looking outlook for IT funding in 2021. We will conclude with a Q&A session. We encourage you to please send your questions and participate proactively. We will be doing polling throughout the conversation, and we encourage you to send your Q&A, your questions, so that we can address it at the end of the webinar. So without further ado, let me welcome Guillaume and pass the word over to you.
Thank you, Brenda. Thank you for having me here today, and thank you everyone for attending. It's always a pleasure and a delight to be with everyone. Before we begin, we'd like to hear from you, the audience, in order to how you expect telehealth to grow in the coming 5 years. So you have to please select one of the following options. If you don't expect telehealth to grow at all, 0 to 5% per year, 5 to 10% per year, 10 to 20% a year, or over 20% per year. So please select one of the following options and click the submit button. As Brenda mentioned, we'll be sprinkling some of these poll questions throughout the presentation here today because we'd love to hear your feedback as experts in the field. I also want to take advantage of this quick intermission to remind you that a lot of the data that we'll be seeing here today in the presentation comes from our Hospice database, which surveys over 20,000 hospital institutions across Latin America. Overlaid on that will be commentary from Dr. Enrique Ruelas and from Alec Lee to show some of the analysis that can be done with said information. So here we go. The majority of you believe that telehealth will grow considerably in the coming 5 years, certainly over 10%, and even over 20%. Half the audience here today believes that telehealth services will grow at over 20% per year. This certainly is welcome news, and we'll be delving into that in just a moment. So thank you, MC, for providing that insight and controlling the poll questions. If we look at the hospital landscape and hospital capacity on a global level, we see that there's approximately 100,000 institutions worldwide. About a quarter of those are in developed economies like the United States, Canada, Japan, Europe, Australia, and many others. We see that nearly 1/4 of the world's hospitals are also in China, and 1/3 is in Latin America. We're talking about nearly 22,000 institutions in our region of Latin America. So Latin America really is a vast hospital network, a vast hospital landscape and market, and that's why it's so important for global companies when looking for international expansion. In fact, if we address a list of the top 10 emerging markets by number of hospitals per country, we see that 4 of these markets are in Latin America, specifically Brazil, Mexico, Colombia, and Argentina. Chile, while being a very small market, is also a key market, as we'll be looking into that in just a moment, for the technology penetration and the penetration of services like telehealth in that market. So as I was saying, Latin America has a very vast and expansive hospital network and hospital infrastructure. We're talking about nearly 22,000 institutions, almost 1 million hospital beds, and 50,000 operating rooms. But there are major differences between hospitals in Latin America and hospitals of other regions. One of those key differences is the average hospital size. We see that hospitals in Latin America typically have an average size of approximately 46 beds per institution, when compared to an average of 160 in the United States and Europe. And this difference becomes even more stark when we're comparing and contrasting public institutions versus private institutions. And nowhere is this more relevant and prevalent than in Mexico, where we see that the average private institution in Mexico only has about 13 beds compared to public institutions of over 100 beds. So what does this mean in the context of telemedicine or telehealth in this case? Well, firstly, that the Latin American hospital market is much more fragmented than elsewhere in the world. There are many smaller players. There are also fewer hospitals with the capacity to develop centers of expertise, so develop high specialization to become spoke sites, and we'll get into that concept in just a second. Also, hospitals don't have the same leveraging capabilities, whether that's on a financial standpoint or on an expertise standpoint, as other regions of the world. And we all know that telehealth programs can be very costly, so we definitely need that leveraging in order to be able to conduct those investments. Enrique, I'd like to ask you a first series of questions. With smaller hospitals in Latin America than in other regions, what does this mean for adoption of services like telehealth? And are there certain hospital groups or maybe certain hospital segments that are more prone to conducting that investment into telehealth than others?
Good morning to you all. Good morning, Guillaume. Good morning, Alec. It's a pleasure for me to be with you this morning. I think that your question, Guillaume, is absolutely crucial, because when we talk about smaller hospitals, we have to define what's the size that we are talking about. The information that provides a hospice scope is very, very useful to know that. And I think that we have to differentiate also between public and private hospitals. So by saying this, I think that we know now that the smallest hospitals in the region are not able maybe to, so far, to go into telehealth as one might think. And when I say smallest hospitals, I'm talking about our houses in the region that are adapted as hospitals in the private sector. They may have 5 beds, 8 beds. It's hard to think that they will move into that direction soon. However, we may have this largest private hospitals, over 50 beds, which are large in our region and over. And of course, public sector hospitals that have a lot more beds. These are the hospitals that should be focused as a targets for helping them to utilize this technology that, as I'm going to mention in a minute, it's absolutely necessary now after the pandemic.
Terrific. Thank you, Enrique, for your commentary and insight. So at this point, it's really important to distinguish between what's telemedicine and telehealth. And I think that's something that needs to be clarified for the audience here, where telemedicine typically focuses on the clinical aspects of healthcare. Telehealth covers a much broader spectrum of services, and even goes into the additional non-clinical functions, such as trainings, education, meetings, really the elements that help hospitals and clinics function and operate effectively and efficiently. So we see really telehealth taking on 3 major forms in Latin America. The first is the interactive medicine, so where physicians and patients can communicate remotely. A second step is remote patient monitoring, that allows caregivers to monitor patients who use mobile medical equipment to collect data. And that data can be blood pressure, it can be blood sugars, it can be a whole variety of elements. And finally, the store and forward telehealth, where providers can share patients' health information to other specialists. What's also fascinating is to see how telemedicine and telehealth are shaping and transforming multiple areas of the hospital setting. From the primary care institutions all the way to in-hospital monitoring and even remote services to schools and workplaces. In a context like COVID and the pandemic that we're currently living through, this is more critical and crucial than ever. So let me ask you this, Enrique. What are some of the opportunities for telehealth in Latin America? And specifically, what does this mean in the context of a pandemic like COVID?
Well, if we analyze the trends now, we are facing a very hard situation to cope with. First, because we already had in the region an increase in the number of chronic patients, particularly patients with diabetes and obesity and these kinds of things. On the other hand, because we also are having an increase in the number of certain kinds of cancer patients. Now, with the pandemic, and as we might talk later, the access to health services had been blocked by either fear to get COVID in hospitals, or because hospitals are full of patients with COVID, so they don't have the capacity to take care of them. So with that trend of increasing these kinds of patients, all what you've said here, Guillaume, is absolutely necessary. Interactive medicine, remote patient monitoring, store and forward. And we are seeing it now, right now. We never thought that this would happen as soon as it is happening now. So I have no doubt that there is a lot of room for telehealth now due to the pandemic.
Absolutely, thank you. Thank you for that commentary. Now, when we think of telemedicine or telehealth, we often think of a single area of expertise that's lending out its knowledge to others. But the reality of operations of telehealth services is quite different. We have to recognize that there's differences between hub sites and spoke sites, as well as certain institutions that can be both a hub and a spoke at the same time. So lend out expertise when required, but also seek out expertise on certain areas that are not their specialty. And together, this really forms an intricate web of knowledge and knowledge access where individuals and other institutions can tap into one another and into one another's expertise throughout. Now, one of the uniquenesses about Latin America is the ability to conduct international telemedicine because of the common language throughout the region, to the exception of Brazil and certain other countries, notably. A majority of countries speak Spanish, which can lend itself as an opportune area for international telemedicine, and we're seeing the rises of that as well. But one of the key challenges that we also see is the ability to conduct that high value, high investment into telemedicine and telehealth programs. My colleague Alec is going to be discussing that in just a moment. So initially, there are three areas of high convenience for telemedicine and telehealth programs. The first of which is to increase access, and that was the starting point in the initialization of telehealth many years ago, to enable patients in remote areas to access expertise. But now with the changing world that we live in and the growth of the mega cities like Mexico City, like Sao Paulo, Bogota, Santiago, Buenos Aires, traffic within these cities and mobility within these cities can be just as challenging as going from one location to a completely different or remote location within the same country. And so quicker access is certainly a plus and a value today that was very different 20, 30 years ago when telemedicine initially started. So increased access to healthcare is both from a remote standpoint as well as within the same city. Another key element is optimizing medical infrastructure. So the need for not necessarily investing in more brick and mortar institutions, but rather capitalizing and optimizing the current existing infrastructure that is in place. Thirdly, the efficiency in reducing costs. And when we're talking about the cost reduction, we have to look at it both from the time perspective of physicians and of patients, as well as the hard costs and investments into health services. All of that really leads to greater convenience of care. And telemedicine, as I was saying, has been around for many years. Teleradiology, for instance, existed back in the 1960s, but investment in telehealth has been one of the barriers to growth over the years. What's interesting, however, is that we're seeing growth now in certain areas that don't require as much investment, such as telepsychiatry, for instance, where a patient and a physician or a doctor can communicate over interactive platforms such as the one we're using here today. In all of this, regardless of the context, as Enrique, you just mentioned, the context of COVID-19 can really be a catalyst for broader change and growth in telehealth across Latin America. Some reports we're seeing here today expect telehealth services to grow up to 20% over the next 5 years. So very much in line with what our audience was commenting just a moment ago. So in your opinion today, Enrique, when we're talking about the public sector and the private sector, what are the key benefits that you see for telehealth services in each of those realms?
Let me start by the public sector. The public sector has a huge challenge now in order to cope, as I mentioned, with this delayed demand on the one hand, but on the other hand, to cope with the need of the population to receive high quality care. And as you've just mentioned, the access that telehealth can provide by providing remote services is very important. I think that the public sector will have to learn very fast how to take advantage of these technologies to do that. I don't see it now, right now in Mexico at least, maybe because we are facing right now the pandemic and everybody is very concerned and very busy dealing with these kinds of problems of the pandemic. Yet, in the near future, and you are pointing towards 2025, I have no question that the governments will be benefited by this kind of technologies and will become more efficient. When we move into the private sector, we are already seeing this. And we are seeing how they are becoming more efficient by providing healthcare at home from the hospitals, from the doctor's offices, without having to travel one or the other to the other point. I would add, you mentioned that we might see very soon, or we are seeing already, maybe in the Latin American region, how you can share services between countries. Well, we already know that. We know how you can receive services from India to the US, for example, radiology. That already exists. So I don't see why it won't happen by 2025 in the region a lot more frequently than it is today.
Absolutely, no, very good points, very good points. Now, going back, we monitor through the Hospice Scope database. We track hospitals and we monitor their capacity. And when we're talking about capacity, we refer to hospital beds, equipment, technology, and in this case, telemedicine and telehealth. Now, it's fascinating to see that public institutions are ahead of their private counterparts in telehealth adoption across Latin America, typically by around 30% more. When we look at hospital capacity and hospital infrastructure, though, we really take into consideration 3 factors and 3 pillars. The first of which is the number of institutions in the country, like hospitals and clinics. The second is how equipped they are with beds, with imaging equipment, with technology, and in this case, telehealth services. And thirdly is the component of skilled labor within the institution. And those can be physicians, they can be nurses, doctors, attendants, etc., but also management. And Enrique, I'm going to pass that on to you in just a second. It's fascinating to see nonetheless here, when we're looking at public and private institutions and contrasting them, that the public institutions seem to be initially better equipped than their private institution counterparts to deal with telehealth. Another fascinating element that we see here is that while Latin America typically is farther behind than the United States or Europe in terms of telemedicine and telehealth adoption, Chile stands out. Chile stands out dramatically. It's even up to the same levels as the United States in terms of telehealth penetration. And so, Enrique, I think there's two great comments here that I'd like to hear from you. The first of which is in relation to your knowledge and expertise of the Chilean context, as well as the Mexican context. What makes Chile so unique? And are there certain lessons or best practices that we could be considering from the Chilean case study? Additionally, also on the point of the public and the private institutions, what are we seeing, and how do these factors come into play to see who's really better served at implementing telehealth in the years to come?
I think that there is a major lesson from the Chilean experience, and it's the fact that they've been able to create scale. I think that's a key component of the whole thing. Now, having said that, Guillaume, I think that it's not only to creating scale what is important, but how to take advantage of that scale. And that has to do with something that you mentioned just before, management skills. What do I mean by that? You can create scale, you can get the advantages of that, and yet, if you don't know how to prioritize, if you don't know how to make those savings by creating scale more efficient for your operation, then you gain nothing. So it's a combination, I would think, of a scale plus, I'm sure, a good way of prioritizing where to devote the savings that you create by creating that scale. So I would think that this is one of the lessons. Then, if you prioritize and you decide which population is going to be benefited by those technologies, those facilities, those human resources, then you'll be able to obtain better health for the population. Which population? The ones that are now at high risk. Aging population, chronic patients, cancer patients. We know now that these are the populations that are in more need in the region now.
Terrific, thank you. And so finally, we look at the types of institutions in Latin America and their telehealth penetration. And what's fascinating here is when we look at the level of care of the different hospitals across the region, we see that 58% of institutions are general hospitals. Yet when we look at telehealth penetration, we see that penetration really is correlated to the level of specialization. And however more sophisticated a hospital is, however more complex its services can be, the greater the penetration of telehealth services. So with that in mind, Enrique, I'd like to ask you if there's why that correlation exists to begin with, if you have some thoughts on that. And also, very importantly, if there's an opportunity for telehealth services to become part of the day-to-day routine of general institutions, where we see that right now only approximately 23% of general hospitals offer telehealth services.
Again, as I said, if we think about 2025 and maybe 2030, I have no question that this is going to change. And it's going to change basically because we now know that many problems arriving in hospitals due to COVID-19 right now are because primary health is very weak in our region. So we'll have to strengthen primary care. This is so obvious now that it's going to be hard for governments to forget this experience. And we'll have to see how they are moving faster and better into primary care. So the penetration into primary care, I think, is going to be higher than it is today. On the other hand, as I mentioned, also, general hospitals will have to operate now or learn to operate now out of their own walls, going into the populations that normally tend to go to emergency services, emergency units, because they have a flu. And maybe they won't need to do that when hospitals are able to first coordinate better with the network of primary care facilities around them, and second, when they are able to provide emergency services even for those people that don't have really huge problems, health problems, and they don't need to arrive in an emergency room. So I think that the penetration in the next 5 to 10 years is going to be a lot more than we are seeing now.
Terrific, great. Thank you for all that insight and commentary, Enrique. I'd like to remind everyone here in the audience that all of this data, again, comes from a Hospice Scope database, and please contact FrontierView for more information about that. There's over 200 data points per institution that we gather and collect year over year, and we update. And at this point, I'd like to pass it to our colleague Alec Lee to look into the outlook of IT funding in Latin American hospitals for 2021. Alec, over to you.
Perfect. Thanks, Guillaume. So we brought up some very interesting questions, particularly around the impact of institution size on telehealth penetration. And we've seen that the group believes that you're going to have a major expansion of telehealth over the next several years. And so the question I'm going to look to address here specifically is how can that be financed? But more importantly than is there going to be expansion or not, where is that expansion going to be? So we know that some specific trends, obviously in 2020, have driven the focus on telehealth utilization, but the trends moving into 2021 and 2022, specifically from a focus standpoint from the MOHs within the region and also a financing standpoint, will be much different. So to begin with, what we've done here is try to untangle the major trends that have come out of this pandemic into the trends looking at addressing the pandemic and those that we call a collateral impact. And so obviously, in that first instance, we've had a major expansion of telehealth in order to provide continued access to patients for primary care, psychology care, and other basic services in the absence of their ability to go to the clinical setting. Now, when we look at the collateral impact and the extension into 2021, some other trends are going to become more important for answering where's the opportunity going to be, what are the investments that need to be made. And those are specifically going to be around addressing the delayed treatment of NCDs, the shift out of the private insurance and Social Security into the public systems, and the increased use of out-of-pocket spending to finance primary care as the overall systemic financing weakens into 2021. So this is what I'm going to look at over the next several minutes and try to project where those opportunities are going to be in the near and medium term. If we move to the next page, the first thing I want to call our attention to is, again, highlighting why we've seen this surge in 2020. And this is important to think about how the opportunity will shift moving into 2021. And it's been stated by Enrique and Guillaume both during the first comments, is that the major driver here has been patient fear. So if we look at patient fear within Latin America, specifically Brazil and Mexico, the patient's willingness to go back to the clinical setting, it's been much higher than across the rest of the world due to the management of the communication with patients, as well as the extent of the pandemic within the region. And that's, in the first instance, driven, again, a demand for telehealth services, particularly from patients that might think they've been infected with COVID or having challenges from a mental health perspective within isolation. Now, if we move to the next page, there's another result of this high level of patient fear. And we'll see on the next page, effectively, one more page, thank you, perfect. We'll see on the next page, effectively, that secondary impact has been on the treatment, diagnosis and treatment of non-communicable diseases. So across the region, we've obviously seen this large impact on oncology treatment, but also diagnosis of new patient and diagnosis of new patient within the rare and orphan disease area. And the challenge being is that we haven't actually seen telehealth solutions being expanded on at scale to address these specific problems. And in fact, we can see that as an example in Chile. If we go to the next page, please, we'll see that, again, that concentration of telehealth utilization has been specifically, and this is looking for Chile's SAPRE system, but can be expanded largely for the region, has been for general medicine and mental health care, while the treatment of these NCDs and follow-up with patients with chronic diseases has been minimal at best. So that really leaves us with the question of, if we're exiting the pandemic sometime in mid-2021, and you're not going to need to use telehealth services as much to provide care to patients with a high level of fear to access the clinical setting, what does this mean for the shift in demand in order to address this backlog of patients, and in order to continue to reduce costs in the system, especially as you're seeing falling revenues for public and private payers? So I'd like to ask, if we move to the next page, in fact, we just have a question before I get into that, starting to project where we're going to go. So I think we're going to move on for the sake of time with that question, but what we want to do here is, in fact, try to project, okay, so where we're going to go. And the fact of the matter is, if we look at the numbers that we have so far, so we don't have a lot of numbers within Latin America, but what's interesting was we have some examples from Medicaid data in the United States, where patient fear levels have already started to drop. And in fact, we've seen a significant, about a 60% drop in telehealth utilization already in primary care from the peak of the pandemic to today within the Medicaid data in the United States, which would suggest that, again, you're going to have a major shift out of the current trend that you're seeing for accessing primary care due to that patient fear levels, and the opportunity will shift to other areas. And so looking at where that's going to go, the first question we have is the impact on financing within the region. So the first major collateral trend that I'm going to highlight here is the shift into the public system. So we've seen a major decline in Social Security coverage. We've also seen a major decline, a significant decline in private insurance coverage. So a 2.6% drop so far within Brazil's private insurance system, a 2.3% drop in beneficiaries in Chile's SAPRE system. And all those beneficiaries are going to the public payers. So in Argentina, going to the pure public system, in Brazil, going to SUS, in Chile, going to FONASA, and they're needing to be covered out of general government spending. And as we know, if we go to the next page, the challenge with that being is that if we look at the evolution of finances into 2021, governments across the board have had to increase spending significantly in 2020 to both cover COVID treatment, but also provide economic stimulus. And the planned budgets for 2021 are not only significantly below the 2020 spending for the public health systems, but more importantly, if we adjust on a per capita basis, so you're seeing more patients moving into the public systems, they're actually represent a reduction in per capita spending. So in other words, you're going to have less money in the public system per person being covered by those public entities, which the impact of that being, if we move forward, is in fact the governments are having to look exactly where they want to cut. So on the next page, please, where they want to cut current expenditures. And those cuts, if we open up the budgets, are falling in effectively 2 or 3 areas. The first area is going to be administration, so administration budget people. The second is going to be in investment, so in hospital infrastructure, equipment, et cetera. The third that we're seeing, unfortunately, is in IT budget. So here we're taking a snapshot of the proposed SUS federal budget for 2021. We see a significant reduction in IT budgets across major funds. And then we're also looking here again at that the Chilean budget for 2021. We see significant reduction in the budget for investment, but also in once again within the digital hospital budget, which was effectively cut dramatically by the last Minister of Health, the Minister Manielich, previous to Minister Paris, who took over a few months ago. So again, this is out of necessity. Because you're seeing a shift of beneficiaries into the public system. You're going to have a backlog of treatments and that they're going to have to be treated with lower per capita allocation. So you have to reduce somewhere. So I'd like to look at a couple of more trends before trying to project what this actually means for where the opportunity is going to be. If we move to the next page, there's shifting to the private sector. At the same time that we're seeing this reduction in per capita budgets for the public system because the inflow of beneficiaries and the pressure on public overall public finances, we've also seen that the private hospitals have witnessed a decline in overall their overall margins in 2020. And this is a number of factors. They don't have their higher margin procedures being conducted. You also see that they're unable to adjust some of their fixed costs as you don't have those procedures coming in, and they continue to have to pay down previous capital investments. And that's going to continue to shift their need to focus more and more of their spending within their operational budgets against their capital investment budgets moving into 2021, just as you're seeing within the public side. Now, if we move to the next page, there's also one other really important trend that could begin to really take some pressure off both the public and private systems and begin to create a greater alignment and opportunity for current, let's say, investment in the near term. And that's going to be the expansion of PPP agreements to address the backlog of patients that we're going to have both from a diagnostic and treatment perspective, but also address the question of where does the actual financing come from. And we know that we saw some of that accelerating in Chile in the past. We saw Mexico decelerating their PPP agreements. But within the pandemic, we've seen the expansion of access for public beneficiaries in private hospitals accelerate across the board in Peru, within EAMS in Mexico, within the state of various states in Brazil. And we believe that that's going to accelerate moving to 2021 and shift more of those public patients into large-scale private institutions, which could have the capacity to invest within telehealth. And the second trend here is going to be the outcome in 2021 from the pressure. The financial pressures will also likely accelerate M&A activity within both the private payer system, but also within the private provider system. That will, again, lead us to scale within both sides, both the payer and provider side, and allow for an acceleration of some of those investments. So overall, what we've seen in wrapping up here with our effective projections for where the opportunity is going to be, we've seen that the trend driving telehealth adoption in 2020, which has been the increase in patient fear and accessing primary care and mental health care through telehealth platforms, is likely to decline moving into 2021, hopefully, as we move out of the pandemic conditions. The collateral impacts of the pandemic have been to basically in 2021 decrease public per capita spending, putting pressure on investment budgets, but also IT budgets. And it's also been to impact private hospital margins, which means that they're going to likely to be more hesitant with their investment budgets in 2021. But third, it's also accelerated some trends that can create greater scale. So consolidation, M&A within the private provider space, M&A within the private payer space. And also, and one factor we're going to talk about is likely an expansion of out-of-pocket spending moving into 2021 for patients that want to retake or restart their diagnosis or treatment that they might have delayed in 2020. So what does that mean for the opportunity? It effectively means that you're likely to see growth, but it's actually likely to shift dramatically where it's going to be. So what we've done here is broken up, again, the telehealth opportunity in different business models. The B2C is so directly to consumer, out of pocket. The B2B to C, so basically selling these services directly to companies, which then provide them directly to their employees. The B2G to C, so going to the governments and then to the patient, and the B to payer or B2P to C, so going through the payers. So within this trend analysis, the major key takeaway is twofold. First of all, we're likely to see the government-provided services through telehealth for primary care within 2021 decline significantly due to the pulling back from the pandemic conditions and the fact that patient fear is going to drop dramatically. But that opportunity will shift, and the opportunity will shift specifically, first of all, to a greater utilization from a B2C perspective, so from out-of-pocket spending for consumers wanting to access care in 2021 at a lower cost with a backlog of access or greater waiting lines in the public systems. Also from a B2B to C perspective, with the employers needing to continue to provide access, especially for diagnosis and patient follow-up when they're exiting the pandemic. And then looking to reduce costs for governments and private payers, especially the larger scale private payers, from a monitoring and physician-to-physician consultation perspective, again, in the context of having to address the backlog of diagnosis and treatment. So I think the key takeaway again here is that the opportunity will be here, but it's going to shift dramatically, and the interest involved will be quite different. So I wanted to pause here and take questions, and actually one last question for Enrique here, and that's going to be, what within this shift in the demand for telehealth services, what's the biggest planning challenge that governments are going to face, understanding that things will be completely different in 2021 than they were in 2020, and the patient is likely to be accessing care in a different manner?
Sure, Alec. Two comments. One, what our audience have seen so far is an excellent example of how the combination of information from Hospice scope and the information provided by FrontierView through Alec is the best thing we can do in order to anticipate the future. You saw here trends. We've talked about this catalyst of the pandemic, and we are seeing the shifts, which are obvious. My first comment is telehealth is here to stay and grow. Now, the second comment has to do with planning. What we see in most countries in Latin America is that governments plan with one thing in mind: how much money I will spend next year according to what I spent last year. And so the basic assumption is that they will increase only the budget only based on inflation rate. And instead of saying, what do we need to do according to the new trends, according to what we want to do in order to improve our system, so then we provide the funds and we find the funds to do what should be done and not what we have to do because we did it in the past. I think that's a major shift that we will need to see in the governments in order to make planning not a rigid projection of trends, but an innovative instrument of making our systems better.
No, absolutely perfect. I couldn't agree more. Excellent. So, Brenda, if we have the audience questions, I think we'll go ahead and take those now.
Great. Well, thank you so much, Alec, and Enrique and Guillaume, for all your commentary. We do have several questions, so as a reminder, you can send them to FrontierView webinars on the Q&A box. The first question we have is for Alec. Can we comment on the implementation of telehealth business models for companies working directly with public institutions? And secondary to that, do you have examples of PPPs, public-private partnerships?
Perfect. So from a public institution perspective, it really depends on the specific therapy that you're looking at addressing, the financing mechanism, how they're reimbursing the different hospitals within the public system for utilizing telehealth. So I think that's a question that we need to take offline in order to get into more detail and understand specifically the payer system that you're looking at trying to work more closely with. If you can remind me the second question, I apologize.
Any examples of public-private partnerships?
Yeah, the public-private partnerships so far within Latin America, we're not necessarily focusing so much on providing the telehealth platforms. What we've seen so far is an expansion of trying to continue to provide access to non-COVID treatment to public sector beneficiaries. So the public hospital has been overwhelmed with COVID patients. And so more and more the public health systems are looking to shift those non-COVID patients to private hospitals. And we've seen that in Mexico, in Peru, in Chile, and in other regions, which obviously begins to facilitate those conversations for expanded PPP arrangements moving into 2021, as it's really a cultural shift in many of these cases, especially Mexico.
Wow, we're coming up with so many questions here. Thank you so much, Alec. So we have time for one more question, and this question is for Dr. Hueldas. Do you think integral services companies in Mexico can be key players to expand telehealth adoption at public sector with equipment investments through tenders?
Thanks, Brenda. Can you repeat the first phrase? What kinds of companies?
Integral services.
Okay. My answer is that we have now a lot of uncertainty about the future of our healthcare system. Policies are changing fast and very deep, so deeply. So I don't know what to say, unfortunately.
We can most certainly follow up with this question. I don't think we will have enough time, so maybe we can come back to the audience with more questions and make sure that we can address them in detail. I do want to leave a little bit of time for all of you to just say some final remarks. And maybe we can start with you, Dr. Hueldas. Are there any comments or last-minute remarks before we conclude our webinar today?
My final comment is telehealth is, as I said, here to stay, but it's going to be the future from now on.
And Guillaume?
Thank you, Brenda. I think it comes back to a question of scale. I think it comes back to a question of needs and necessities in terms of the healthcare sector, whether that's treating chronic diseases, diabetes, or the aging population. We need to be able to have scalable solutions, and telehealth is the only scalable solution that's highly cost effective and that will help us address the needs of the evolving population in the years to come and make sure that we tackle the challenges, the healthcare challenges that are ahead. So I want to thank everyone for participating today.
Thank you so much, Guillaume, and over to you, Alec.
Sure thing. I think my last comment would be keep an eye on reimbursement, because if we come out of the pandemic and patients can go back to the clinical setting, no institution, at least private, is going to want to continue to provide telehealth services if they're not getting reimbursed at the same level as in-person consultations. And that's really going to be a major driver beyond scale of continued adoption. So I think that's a really important factor to keep an eye on and stay close to.
Thank you so much.
Thanks, everyone.
Thank you so much, Alec, Enrique, Guillaume. Thank you so much for your time. Your contributions today were great. We received many questions, so we'll come back to you and the audience with detailed answers. And as always, come to us if you have any questions or need any support. Thank you again for the time.
Thank you, everyone. Bye now.
Thank you.